drugs, or ideas, what you consume influences who you become. On the Mind and Matter podcast, we learn together from the best scientists and thinkers alive today about how your mind-body reacts to what you feed it. Before starting Mind and Matter, I spent 10 years in academia doing scientific research. I got a PhD in neuroscience where I focused on neuroendocrinology and the neurobiology of behavior, and before that, I specialized in molecular, developmental, and evolutionary genetics. I use my scientific background to help parse and translate the information that guests share on the podcast. In addition to the podcast, I write long-form written content inspired by the show where I integrate what I've learned across episodes. I also have a free weekly newsletter where I provide you with upcoming guests, share links, and provide commentary on scientific studies and research that I'm reading, and more. Visit mindandmatter.substack.com to find all of my content. You are about to listen to the full episode, but there will be 1 to 2 short ads immediately following this before the conversation. If you would like to hear ad-free episodes and get early access before they release more widely, become a paid subscriber at the Mind and Matter Substack at mindandmatter.substack.com. Becoming a paid subscriber is a way to directly support my efforts, allowing me to make more episodes and higher quality episodes, and also helping to free up my time so that I can spend more of it on doing research and synthesizing results from the podcast and from the literature so that I can do more things like writing on the Substack, putting more content into the newsletter, and getting these things out more frequently. So if you want to support the show and get ad-free episodes, go to mindandmatter.substack.com. Hey everyone, I want to take just a minute to tell you about a really cool health monitoring device I've been using called Lumen. It's a handheld, pocket-sized device with a sleek design. The Lumen device measures CO2 levels in your breath, which allows their technology to determine the extent to which your body is burning fats versus carbohydrates. Lumen helps improve your metabolic flexibility, your body's efficiency in shifting between using fats and carbs for energy. I use this device in the morning or before bed or after meals or after workouts to track my metabolism. With just a couple weeks of use, I learned a lot about which foods were causing my body to burn mostly fat, mostly carbs, or both, as well as how long I needed to fast and how hard I needed to exercise to promote fat burning. Being able to track whether your body is burning fat versus carbs will help you figure out how your body responds to your lifestyle and whether or not your weight loss and fitness strategies are actually working. Lumen is great for anyone looking to optimize their health for either weight loss or athletic performance. Their easy-to-use app allows you to track your results together with what you're eating and how you're exercising, and it syncs with other devices like the Apple Watch. Click the link in the episode description to learn more and use the code MINDMATTER, MINDMATTER, to get 10% off your Lumen device today. That's on top of the site-wide sale they are currently running, and the Lumen device is eligible to be paid for with FSA and HSA health accounts. Check out the link in the episode description for more info. Dr. Pekka Karhunen, thank you for joining me.
Okay. Hello.
Can you tell everyone a little bit about who you are and what you study?
My basic education is that I'm a medical doctor, and professionally I have acted as a forensic pathologist for several tens of years. And sorry, I have to get this hearing aid.
Oh, no worries.
Okay. Okay, now it's in place. So, I have been interested in cardiovascular diseases for a long time, and the reason is that I have worked as a forensic pathologist, and in Finland, the legislation is such that all sudden out-of-hospital deaths will come to the table of the forensic pathologist. And that's why I have been in the position to open about 10,000 coronary arteries by scissors. One day I realized that there are not many doctors in that position that they can keep in their hands the coronary arteries. So I decided to collect a biobank of coronary arteries, and this is an unique biobank. I
So
think.
as a pathologist, you've looked at thousands and thousands of coronary arteries. You've opened
Yes,
people up. You've seen these. That's part of your job. After they die, you look at
yes,
them,
yes,
and you've
yes.
created a large database of this stuff.
Yeah, yeah, and a lot of understanding what is happening in the coronary arteries.
And so normally when we think about heart disease and cardiovascular disease, one of the first things you'll talk about is cholesterol. LDL cholesterol. Obviously, we've got medications called statins that lower LDL cholesterol. And this comes from the belief that having high LDL cholesterol is what drives atherosclerosis. Let's unpack some of the pieces here for people in terms of the basic biology and then tie that to some of the research that you've done. When we talk about LDL cholesterol, what is that exactly, and what is its normal function? What is it doing in our bodies that, why is it even there?
You mean cholesterol? Cholesterol is very important for every people. It's the basic, one of the basics of the life, and without cholesterol you cannot get along. But we talk about so-called good cholesterol and so-called bad cholesterol, and the bad cholesterol is so-called low density lipoprotein, and in the context of coronary artery disease, we still speak about oxidized low density cholesterol. That is the bad guy in this theater. And that it is thought that this oxidized LDL or low density cholesterol is treated by the host, or his or her immune system is treated as a foreign substance, and it starts an immunological inflammation against that oxidized cholesterol, trying to get rid of that. And because it's very difficult, so the result is a chronic inflammation in the coronary arteries and coronary arterioles.
So the idea is if the cholesterol becomes oxidized, it's not different. The body views it as a foreign thing rather than something that should be there. And then you get immune cells basically eating that oxidized cholesterol, and this leads to an inflammatory state.
Yes, that's right.
And so where does that happen? Where does the cholesterol get oxidized? Is it in the plaque of the artery? Is it in the bloodstream? And then where do the immune cells find it and start eating it?
No, it's the cholesterol is constantly flowing through the wall of the coronary artery, and for reason or other, it becomes oxidized, and when it is found that it is, when the immune system finds that it is oxidized, it ingests the cholesterol inside the macrophages, and these macrophages are accumulating this cholesterol, and finally we get so-called foam cells from these macrophages, and these foam cells go together and form a cholesterol-containing area that we call atheroma.
So foam cells are they're macrophages that have been changed? Are they now behaving differently? Are they working properly, or are they dysfunctional?
No, they are no more working. I think that they are mostly dead.
So they ingest this ox-LDL, and the macrophages basically get sick, and they turn into these things we call foam cells, and they are dysfunctional or even non-functional macrophages. They can even die.
That's true. Yeah.
And so when we talk about cardiovascular disease and a cardiovascular event like a blood clot or a heart attack, this will often be in someone who has atherosclerosis already. So they've had plaque build up in their arteries, and then the plaque will rupture. like something will break, and then this will cause something to happen, maybe a heart attack or a clot, and then they have to go to the hospital, and then they might live and they might die, and then you as a pathologist will take a look at them. But what causes these cardiac events? What causes the plaque to actually rupture and cause a cardiac event?
Ah, it has been not known very exactly what is the reason why this coronary plaque ruptures. It has been thought that the more cholesterol the atheroma contains, the more the intraplaque tension has been rising, and this increased pressure inside the cholesterol atheroma has been thought to be one of the reasons why the atheroma ruptures and causes the myocardial infarction. And another reason is that sometimes a neovascular artery inside the coronary atheroma ruptures and causes a hemorrhage inside the coronary atheroma, and that's when when this happens, it also increases the pressure inside the coronary plaque, and it has been suspected that that is one of the reasons why the atheroma finally breaks.
Mm-hmm. For plaques, before they rupture, they can obviously keep growing if someone continues living the same lifestyle. Can arterial plaques shrink? Can you make them smaller or go away over time?
I think that it has been thought that giving a lot of statins to the people might cause these coronary atheromas to shrink. And I think that there are some reports that have proven this to be successful. But it's not very easy to do that. I think that one person has to eat a lot of statins to see anything happening. I think that when the cholesterol has been accumulating inside the coronary atheroma, it's almost permanent.
And so, what else is inside of the plaque? Like what gets in there? So obviously you get some cholesterol and fat that builds up in there over time. We mentioned that you can have macrophages, which can turn into foam cells after ingesting oxidized LDL within the plaque. What else can get in the plaque that might be problematic?
I don't know what to say.
But so I guess
what do you mean?
Well, so if you have immune cells in there and they can ingest the oxidized LDL, is it possible that pathogens like bacteria can actually get in there?
Yeah, this so-called infection theory has been it's quite an old. In the end of 1980s, actually Finnish researchers published a paper in Lancet showing that lung pathogen chlamydia pneumoniae, its antibodies against that infectious agent were higher among patients who had myocardial infarction. And 1 year later, they published in British Medical Journal that the same myocardial infarction patients, there were a little more than 100 of those. They also had bad teeth, a lot of dental pathology, assessed by so-called, what is the computed panoramic computed tomography. They were able to see all the teeth, and they found out that it was also associated with myocardial infarction. And it was there was great interest in the whole world about these findings, and they started so-called antibiotics trials, giving antibiotic that was capable of destroying this chlamydia for several months or even years to thousands of patients. And the result was that there were a lot of these trials, and only a few of them were successful. Most of them showed no decrease in the rate of recurrent events. So this so-called infection theory was abandoned for about 20 years.
So is the idea here that, so you see this association sometimes between basically an infection, in this case, a lung infection or something like that, and cardiovascular disease. Is the idea that an infection is somehow triggering the cardiac event?
Yeah. I think that the basic idea for this chlamydia pneumoniae was that it somehow increases the workload of the heart, and that's. I think that the people, there have been publications that have shown actually chlamydia pneumoniae positive particles inside the coronary atheromas, but they have been, how to say, the results have not been very convincing. These are only some papers, and other papers didn't find any immunopositivity for chlamydia pneumoniae. So it was a very weak finding, and also subject to contamination and all kind of technical problems at that time.
But if we have arterial plaques that build up in people, if you can have macrophages get in there and move, they fill up over time, they get bigger. So stuff can get in there. And so I guess it seems like, so bacteria or something could get in there and maybe hide in there. And if you have macrophages eating a lot of oxidized LDL and they turn into these foam cells, then they don't really work anymore. Is the plaque potentially a good place where something like a pathogen can hide and escape detection by the immune system?
It seems so that normally, when the people have normally arteries, there are times that they got bacteremia from, for example, if you are brushing your teeth, you got a small bacteremia. If you go to the dentist and have your teeth extracted, it causes a huge bacteremia. And within 15 or 20 minutes, everything has disappeared from the blood. So the innate immune system takes care of these bacteria that enter the circulation and destroys them. But when the individual has developed a coronary atheroma, the inside of the coronary atheroma becomes hypoxic. And this starts the development of so-called neovascular channels that form a highway from the circulation straight inside to the coronary plaque. And it's possible that when you have this highway open into your coronary atheroma and you have your teeth extracted and you got the bacteremia, at that time it's possible that the bacteria go inside to the atheroma. And when they got there, they pass the immune system. So they are safe there. And they start forming a so-called biofilm. In the biofilm, they are living like in a small village.
So basically, bacteria can get into the bloodstream. That's sort of normal. The immune system is expecting to find them there and can clear them out. It's very good at that. It can do it very quickly. But under certain conditions, there are ways or chances or opportunities for some bacteria to get sort of into the vasculature, and they're not normally there. They're not kind of supposed to be there. And so the immune system isn't really expecting to see them there. And that can be a way where they hide. And then they start to make these biofilms, which protect them.
Right. Yeah, that's the way that they do.
And so tell me a little bit more about these biofilms. How exactly do those work? What are they made out of? Why are the bacteria making them?
In the biofilm, the bacteria are producing so-called extracellular matrix. It's composed of polysaccharides or cellulose uh, or maybe amyloid fibers and inside this extracellular matrix, it's like a jelly or like a mucoid structure. Inside that, the bacteria usually they slow down the genetic genes that produce the capsular proteins. Mm-hmm. They are like transparent inside the biofilm. And they live there and eat and communicate with each other. And for reason or other, it is known that in the life of a bacterial biofilm, some trigger may cause the activation of the biofilm so that it starts to produce the next generation of capsular bacteria. That is, the capsule is important that the bacteria can penetrate to the surroundings. And we don't know what is the trigger. It has been suspected that so-called, for example, if somebody gets sick with influenza within 1 week, the rate of the risk of the myocardial infarction elevates to 6 times. And it disappears after 1 week. So it might be that influenza might be one of those triggers that cause the biofilm inside the coronary artery to activate and produce virulent bacteria that are capable of to infiltrate the fibrous cap of the coronary artery.
I see. So if bacteria get into the vasculature, they can make these biofilms. They're secreting stuff into the extracellular space outside of the cells. Yes. And it's like a walled village. It's like a village with a wall around it. So they're sort of invisible to the immune system. They're kind of safe in there, and they can live in there and hide in there and stay in there. But they probably can't do much beyond that unless they get through that biofilm. And that's what you're talking about here. At some point, for reasons that are still mysterious, something can trigger the bacteria inside the biofilm, inside the protected village, to start to penetrate it and come out. And perhaps that is related to something like a cardiovascular event where, say, a plaque is ruptured.
That is known from the life of the biofilm. And in the biofilm, the bacteria are the immune system, the macrophages of the immune system do not detect the bacteria anymore because they are covered by the extracellular matrix. And also the antibiotics, they don't penetrate the biofilm, so they are safe. Actually, if you give high amounts of antibiotics, for example, using intravenous route, it might be that you can affect the life or the condition of the biofilm. But this has not been done yet in humans.
And you've done work where you detect, I think, bacteria from the mouth and other places inside of atherosclerotic plaques. Can you talk a little bit about that? What types of bacteria have you found in these plaques, and how do they get there?
Okay, in 2005, I did not know anything about the bacteria in the coronary plaques. But my friend, a professor of biochemistry, he had a researcher. She had learned so-called broad range bacterial PCR. That method it was able to amplify the whole genome of the so-called 16 sRNA gene of the bacteria, and it was quite a difficult technique, and she practiced it, and he asked me that could I give her some coronary arteries just to test the technique, and I gave him a couple of, let's say, I don't remember exactly, but about 10 coronary samples, some from coronary heart disease patients, and also control samples from drowning cases and young patients who died due to accidents. And we were quite surprised to find out that that the final result was that we were able to amplify bacterial DNA, but according to sequencing results, they were all of oral origin.
So bacteria in the mouth are getting inside of these plaques.
Yeah, we thought that we have made in the autopsy room some mistake because it was I had never heard that. Actually, it was the first attempt. It was the first publication, and it was very difficult to get it published because we were quite unsure whether this is true or not, and we got it published. And at the same time, I was studying. I had this sudden cardiac death autopsy series, and we had the possibility to do this panoramic tomographic radiography to assess the whole all the dental pathology that was present in the mouth. And we found out that especially those who died in the early middle age from coronary thrombosis and coronary death, they had they had a lot of dental pathology compared to those who died of other reasons. So I started to be interested in this.
So you already knew that there was this association between dental pathology, basically having bad oral health, and cardiovascular disease. And now you started to use this PCR technique, and you're finding oral bacteria from the mouth inside of these plaques, and so it's starting to come together.
Yeah, these two occasions, how do you say, if somebody kick you to your ass and you go, they were both surprises. I didn't intend to get those results.
It was a serendipitous finding.
Yeah, surprise finding. And
so what's the connection between oxidized LDLs, macrophages, foam cells, and bacteria getting into the plaques? Because I would imagine that the more oxidized LDL that's around, the more you're going to transform macrophages into foam cells, which are basically macrophages that do not work anymore. And the more that happens, the more chance there is for bacteria to actually get into these plaques and spaces and live there, because the immune system is not going to see them.
Yeah. If I understood right your question, the bacteria cannot get into the coronary wall without the development of a cholesterol-containing atheroma.
I see. Yeah. So that's a requirement for them to be able to get into that space.
No.
And so have you observed this now multiple times? Have you verified this, that bacteria from elsewhere in the body can get into these plaques? And do you think that's something that really does happen?
You were asking that if some other bacteria than dental bacteria can get into the plaque.
Yeah, like have you observed this in other instances? Is there something special about the oral bacteria that can get in there, or can potentially any bacteria get in there under the right circumstances?
I think that any bacteria, what is the cause of the bacterium? If you got pneumonia, you certainly got these pneumococcal bacteremia, and it might be possible that these streptococci might go inside the coronary plaque. But we have unpublished results that actually there are in a coronary plaque there are dozens of bacteria that are mostly of oral origin, and there are also gut bacteria and also skin bacteria, but in a minor role. And when you have these bacteria in your mouth, they keep your oral mucosa healthy, and they are very important to be there. But what the oral bacteria do is that they form a biofilm on the surface of the teeth. And this biofilm has a very peculiar organization. The first colonizers are virulent streptococci, then comes Veillonella, and then Prevotella, and there is a certain three-dimensional structure on the surface of the teeth. And I think that we may find a similar organization in the biofilm in the coronary plaque. So it might be that the nature has not many ways to create a biofilm. It might be that the process in the mouth on the surface of the teeth is similar than happens in the coronary, inside the coronary atheroma, when the bacteria are entering the coronary atheroma.
Mm-hmm. So bacteria in the mouth just sort of naturally make biofilms. It's part of how they stick to our teeth and things like that. So it could be that you're finding them in these atheromas, in these plaques, because the biofilm helps them evade immune detection and reside there, and they're just naturally good bacteria at making those things. Hmm. And so what does this mean about cardiovascular disease prevention and treatment? Is there a place for treating this the way we might treat an infection? Can there be benefit? Can you prevent cardiovascular events by somehow treating the bacteria with antibiotics or something like that?
I think that at present we don't have any ways to eradicate the biofilm inside the coronary atheromas.
And does that mean, so because they're in the plaque, because they're protected by biofilms, are they insulated from things like from medicine that we might give someone? Yeah.
But there is another way for the biofilm. One was what I was talking was that the biofilm can activate and produce a next generation of virulent bacteria. But there is also another pathway for the biofilm. It might be that there is no trigger available, and the biofilm lives tens of years, maybe years at least. And what is happening inside the biofilm is that some of the bacteria start to die because the limitation of the nutrition, and it's like a village where is a big graveyard and old transparent bacteria, and it might be that the whole bacterial biofilm may calcify. What happens on the surface of the teeth is that the oral biofilm on the surface of the teeth calcifies, forming so-called dental calculus. Might be that something like that also happens.
So even if the biofilm doesn't rupture or anything like that, you have this plaque in your blood vessels somewhere, and it could be there for years and years. It can be there for so long that the bacteria inside of it basically run out of food and they die. And it's like a graveyard of bacteria, and the whole biofilm entity calcifies, and now you've got this kind of hard, nasty structure in blood vessels.
the clinicians say that the plaque is stabilized.
Stabilized, yeah.
Yeah.
Wow. Okay, so it's not good for bacteria to get into that space, no matter what. Even if it ruptures, that can cause a problem. Even if it doesn't, eventually the whole thing can sort of rot and calcify, and that can be a problem.
We are full of problems.
Yeah. What how has this made you think about atherosclerosis and cardiovascular disease in terms of prevention and how you manage your own lifestyle?
I think that this bacterial biofilm, although this is a new finding, and it might be, I don't know how important it will be, but because this is the first study on it, and I think that what should be done is to try to find out preventive methods to reduce the development of the biofilm, and the lifestyle factors are very important, because the more you succeed in reducing or lowering your cholesterol, the less likely is that you get this cholesterol-laden coronary atheroma that forms the highways for the bacteria. And the more you keep care of your teeth, the more there is possibility that there are no need for teeth extraction, or if you have inflammation in your teeth and you keep on brushing your teeth, it might be that you get this bacteremia more often with diseased teeth than with healthy teeth. So keeping good care of your mouth is very important.
Yeah, but basically what you're saying here is that having poor oral hygiene,
yes,
can predispose you to cardiovascular disease, because bacteria can literally get in through little cuts and openings in your mouth and then get into these plaques elsewhere in the body.
Yeah, I think the dental care is very important. It's more important than people think.
Visit mindandmatter.substack.com to find all of my content. Hey everyone, I want to take just a minute to tell you about one of my cool new affiliate partners called Seed Oil Scout. Seed Oil Scout has a really cool map feature that helps you find restaurants in your area where you can find seed oil-free options. They also have a really cool product scanner, so you can take out the app and use the camera functionality of your phone to scan products in grocery stores and see what's actually in these things. Do they contain seed oils? Do they contain other things that you want to know about that aren't necessarily on the box? This will help you find places to eat and find foods to eat that actually have what you want in them and help you avoid those that don't. So if you're looking to cut back on your seed oil consumption, or you just want to know more about what's in the foods on the shelves at the grocery stores, download Seed Oil Scout today. If you go through the link in the episode description, click into that and you'll see a link to the Seed Oil Scout app. If you go through that link on my support page, you'll be directly helping the podcast, and you'll be able to download this really cool, easy to use app that will help you find healthier food options. So go through the link in the episode description and download Seed Oil Scout today.